First of all, I must congratulate Dr. Vitul Gupta and MAPICON team for inviting me here, and I am really touched by his hospitality and the way he behaved with us. That is phenomenal. And because of Vitul Gupta sir, I could achieve one more milestone today only. I am, for the first time in my life, I am the opening batsman. Otherwise, most of the time I am middleman or last man. So with this, I am talking about pre-diabetes are to be treated or not to be treated. Before that, if you permit me, we can have audience poll sort of thing. How many of you would like to treat pre-diabetes? Raise your hands, please. Me also. How many of you don't like to treat pre-diabetes? Please raise your hands. So all would like to treat pre-diabetes. So what is pre-diabetes? This will be the flow of our talk in next 15 minutes. Pre-diabetes is a condition bridge between the normoglycemia and hyperglycemia of diabetic origin, but the hyperglycemic range is less than the diagnostic criteria for type 2 diabetes. Here we are talking about American Diabetes Association criteria, which we used to follow in most of our studies and most of our talks. We know that normal A1C level is less than 5.7%. Fasting blood glucose or fasting plasma glucose is less than 100 milligram, and post glucose plasma glucose is less than 140. That is normal. In diabetes, it is more than 6.5 is A1C. Fasting blood glucose more than 126, and post glucose it is more than 200. The problem lies here in between the two. They are pre-diabetic patients. These are the patients, and this is the million-dollar question, as Dr. Noria has already pointed out, whether we should treat or not to treat. Let us see. We have both the things we will answer. Points in favor of treating pre-diabetes and not treating pre-diabetes. So before going further, these are two cases where we should understand, and we will come again at the end of the talk. This is first case, 42-year male with family history of diabetes, coronary artery disease, hypertension with obesity, signs of insulin resistance, that is acanthosis. He was feeling lethargic and presented to us with dysglycemia, and A1C was 6.3. Another case, almost similar features, 42-year male but no family history of diabetes or any comorbidity like hypertension and coronary artery disease. BMI is normal, 23, and again presented with A1C of 6.3. There was no sign of insulin resistance. So we will decide whether to treat or not to treat. Again, we can have a poll at this point. Who would like to treat both the cases, or one case, or second case? So keeping in this in mind, these are alarming figures. We have 110 million about diabetes, 136 million pre-diabetes, and 254 million people with generalized obesity, and 351 million patient with central obesity, abdominal obesity. And we all are aware of the fact that these are potential diabetics, counting about 600 million, more than 600 million, which are potential diabetes and can be prevented. That is very important figure, and for a country like ours or Asian countries, we can prevent all this. We all are aware of as the obesity is the precursor of diabetes, and as the BMI increases, the various phenotypes of pre-diabetes, that is impaired fasting glucose, impaired glucose tolerance, and both are increasing with increasing BMI. In last 20 years, what has happened? The overall CV mortality has decreased by 30%, but CV mortality associated with obesity has increased to 3 times. You can see here 2.2 to 6.6. So this is very important, and that is why we have to treat pre-diabetes. This is the prevalence of various phenotypes of pre-diabetes in various ethnicities, Asian, Indians, Caucasians, and this is the meta-analysis of almost 19 studies with 32,000 patients, and we are more susceptible for impaired fasting glucose, impaired glucose tolerance, and even both. This is the natural history of the diabetes. We know that there is, when diabetes is diagnosed, almost 5 to 10 years has passed before diagnosis of diabetes, and by that time there are multiple risk factors which are operating upon and leading to the various complications, and the reason for complications are these: free fatty acid, hypertriglyceridemia, increased visceral adipose tissue, hyperglycemia, increased RAS activation leading to oxidative stress and inflammation, endothelial dysfunction and fibrinolytic dysfunction, all leads to vascular events, and most common complications are macrovascular complication, that is peripheral arterial disease or cardiovascular disease or cerebrovascular accidents. This is the Veteran Health Administration study of about 72,000 patients, which has analyzed the timeline to develop progression of pre-diabetes to diabetes, and at 1 year 35% developed diabetes, and at 2 years 60% developed diabetes if they were not treated or they were not advised anything. Progression of pre-diabetes to diabetes varies from 5 to 20%, even more or less, depending on the population you study, and various other factors like age, obesity, family history, ethnicity, PCOD, history of GDM, baseline A1C, and lifestyle. Meta-analysis of more than 250,000 participants followed for 24 years. Cumulative evidence of developing diabetes was 31 to 41%. So you can imagine the burden of diabetes and pre-diabetes. As Dr. Noria rightly pointed out, this will be the biggest pandemic of pre-diabetes in near future. This is the review of more than 7,000 publications on 40 countries, that prevalence is highest in high income countries about pre-diabetes, but the highest relative growth for pre-diabetes is in low income countries. This is again a matter of stress for country like ours and Asian countries. We all are aware about the fact that pre-diabetes is a risk factor for progression to diabetes, cardiovascular disease, dyslipidemia, hypertension, and it should aggressively prompt you to comprehensive screening for all risk factors. Whom to screen? Those patients who are having obesity or high degree of BMIs, first degree relatives with diabetes or signs of acanthosis nigricans, PCOD, physical inactivity, signs, history of cardiovascular disease, and first degree relatives of type 2 diabetes. Then patients who had GDM in the past or any time hyperglycemia in the past, they should be screened for pre-diabetes. Risk factors for pre-diabetes we have already discussed. The most important is genetic predisposition, and then comes the obesity, and all these are precipitated by older age, physical inactivity, and unhealthy diet. We are aware about the fact that insulin sensitivity is progressively impaired from normoglycemia to type 2 diabetes, and as the glycemia deteriorates, insulin sensitivity decreases. Sorry. This is ASDAB study of more than 10,000 patients, which shows that as the dysglycemia improves, means dysglycemia is increased, there is increased CV mortality and all-cause mortality. Why pre-diabetes to be treated is in a study of 577 patients from 33 clinics in China. They were followed up for 6 years, and they were divided in 4 groups. Control group, diet, exercise and diet plus exercise, and the results are 51% lower incidence of diabetes during the active intervention period and 43% lower incidence at next 20 years. So this is the importance of lifestyle intervention, and the average annual incidence of diabetes was 7% for intervention group versus 11% in the control group. This is the Docking study with longest follow-up, 30-year follow-up has shown that median delay in onset of type 2 diabetes is by 4 years, and there are lesser CV events and lesser microvascular complications and so on. This is rapid and early diagnosis of pre-diabetes. It is very important. This is my paper which was published in the IJCDM for point of care testing of for pre-diabetes. What we did, the attendants of the diabetic patients who were coming with them, we were doing point of care A1C levels in those patients, and we picked up the pre-diabetic patients. Why pre-diabetes treatment is important? Because diabetes reversal is easier and very fast at this point of time as compared to patients who become diabetic and then we try to reverse them. And it is by intensive lifestyle, dietary modification, enhanced physical activity, and it reduces the progression by 40 to 70%. This is phenomenal number. These are various diabetes prevention programs which also suggested 30 to 60% less progression to pre-diabetes to diabetes. This is another direct trial which is again weight loss trial, and those patients who achieved more than 15 kg weight loss, 86% of the patients could achieve remission, and those who sustained it 15% weight loss for 2 years, they almost 70% of the patients could remain in remission. That is very important, that you can maintain normoglycemia for very long time without any medication. Various diabetes prevention programs, DPP program, very famous, commonly known, 31% reduction with metformin and 58% reduction with lifestyle modification. Various drugs are tried and used and found to be efficacious, including all non-hypoglycemic drugs except insulin, except sulfonylureas and glycine analogs. These three are hypoglycemic drugs. Rest other drugs are found to be effective in preventing the progression from pre-diabetes to diabetes. However, ADA recommends metformin treatment for people with pre-diabetes, those who are less than 60 years of age and BMI of 35 along with pre-diabetes. Otherwise, no drug is approved for management of pre-diabetes. For obesity, which is precursor for diabetes, there are treatments. Most of them we can use, logically we can use all those drugs, but not recommended by the guidelines. Weight loss medication, again the same, which are available now, and that can be used for prevention of type 2 diabetes. Very old stop NIDDM trial with acarbose, which reduced 25% reduction in impaired glucose tolerance over a period of about 1200 days, almost 5 years or so, 4 years or so. This is step 10 trial with burning molecule, or most commonly talked about molecule as on today is semaglutide, that is Wegovy, and those patients who achieved weight loss of 20% weight loss, the 81% patient could achieve remission as compared to 14% in placebo arm. Another important point is, you can see here, only 33% patients at the baseline in this step 10 trial having A1C of less than 5.7%. But at the end of 2 years with Wegovy treatment, 65% patients are with A1C of less than 5.7%, that is in normoglycemic range. And in placebo arm, this figure decreased by 30% from 33.9% to 21.4%. These are the various weight loss categories with lifestyle modification, minimum weight loss. This is Wegovy and this is Mounjaro, that is tirzepatide. Now the other side, why pre-diabetes not to be treated? Because different criteria by different organizations for diagnosis of diabetes. Then stigma of a chronic disease which causes mental stress and overdiagnosis and over-medication. All these are very important factors if you label a patient with pre-diabetes. These are the different criteria. WHO has not included A1C in the diagnosis of pre-diabetes. So it is very important. ADA has lowest criteria. ADA has lowest criteria, fasting blood glucose 100 to 126, while WHO and NICE guidelines and International Expert Committee are considering 110 to 126 milligram fasting blood glucose for the diagnosis of pre-diabetes. So if you use ADA criteria, you are over-diagnosing. If you use NICE criteria and WHO criteria, you are under-diagnosing. And the difference is huge, about 20%. So this is the reason why not to treat. Another very important reason, our treat to target for diabetes mellitus are A1C of less than 7% or less, or even by ESD it is less than 6.5%, which is still well above the diagnostic criteria for pre-diabetes. So you have to use your clinical acumen, which patient to be treated, which are not to be treated. Long-term studies are required for evaluating the risk benefits of pharmacotherapy for pre-diabetes. We don't have robust data for in favor or against the pre-diabetes to be treated or not. Then who are the pre-diabetic patients which should not be treated? Those patients who are stable in pre-diabetic range without associated comorbidities like obesity, like hypertension or coronary artery disease or dyslipidemia, are having history of GDM, there is no history of GDM, no PCOD, then they should be watched and should not be treated right at the beginning. If there is incremental or worsening hyperglycemia, then you should start treating. If they are remain stable in that, lifestyle modification are the best treatment. So last slide, a few slides. PD message is pre-diabetes is more prevalent than conversion of pre-diabetes to diabetes, varies from 5 to 20%, even more are low. CV disease and mortality are higher among untreated pre-diabetes. Rapid and early diagnosis is very important. Ask yourself, are we justifying in treating pre-diabetes? Patients who are stable in pre-diabetic range without other risk factors should wait and watch. Stigma, because of the stigma associated with chronic disease like diabetes and pre-diabetes, they must be under surveillance and investigated at regular intervals. If worsening hyperglycemia, worsening comorbidities, then you should treat. Coming back to the two cases, the first case, 42-year male, family history of diabetes, coronary artery disease, hypertension, obese, having signs of insulin resistance, lethargic, presentation is not important, but dysglycemia, he is the patient should be treated. Another patient with 42-year, no family history of any risk factors, BMI is normal, no sign of insulin resistance, A1C is 6.3, should be under observation, regularly investigated. If there is no worsening hyperglycemia, should not be treated, only lifestyle modification should be done. And fortunately, this is accepted in Journal of Association of Physicians of India, and in upcoming issues probably it will be published. So thank you very much.